We're here today with Dr. Sanjay Gupta. When it comes to heart health, it's such a broad topic.
Your overall health is not only dependent on physical body, but also the mental side of things, because everything depends on everything else. The reality is, if you take a statin, you'll never know. You'll never know whether it's done anything. You know, the doctor's saying it, that, oh, it's good for you. The only thing you can be certain of, if you don't take the statin, and if you have a heart attack, then they'll blame you.
All right, so we're back with Dr. Sanjay Gupta. So happy to have you on the channel again. A couple of years ago we had you, and it's really, really a pleasure.
Thank you so much. I was looking at that, and I could see that some people had mistaken me for the CNN guy.
Yeah, but a little bit, you know. But your knowledge is impressive for cardiology, and some of your channel is really, really fascinating, in that you kind of discuss some truths that aren't being told, you know, by the NHS, aren't being told the normal medical community, and you're really, really good at trying to say, hey, you know, maybe there's a different way. So, and you've been very insightful about testosterone treatments and hormone treatments in the past, and I think that really appeals to the people on our channel. So, really, really happy to have you on to discuss it. So, when it comes to heart health, it's such a broad topic. You know, you've got the cardiovascular bit that we're talking about, you know, the plumbing essentially of the vessels and how healthy they are. And when those don't work right, then you have some heart attack or ischemic event, and then that damages your heart. And then you got a whole other set, which you talk about, you know, you got the electrical circuitry of the heart. Your channel talks about atrial fibrillation and all the things people have to deal with that, or even heart failure. Your channel talks about. So I thought we can just start off, and you can tell a little bit about the different types of heart disease, and then how testosterone and other hormones might be able to help it or hurt it, or what we have to look out for. So to you.
Excellent. Well, the first thing I would say is that it's very important to understand that the body is a set of interdependent organ systems. And one of the big mistakes we make is where we see each organ in isolation. Oh, this is heart, this is not gut, and therefore there's no connection. And that is clearly not true, because everything depends on everything else. That's the first thing. And this is one of the biggest mistakes we make, where we say, oh, this is your heart, this is not something else. Everything has a bearing on everything else. Your overall health is not only dependent on physical body, but also the mental side of things, etc. The second thing to say is that the heart is very much the conductor of this orchestra, because it is responsible for pumping blood around the body. It is also true to say that there are many things that also affect the heart, like hormones, and those hormones are produced in different organ systems, etc. So if you have any kind of cardiac dysfunction, then the ultimate problem with that is less blood comes out of the heart. All cardiac dysfunction will lead to a decrement in the amount of blood. And blood is necessary to function. Oxygen is necessary for organs to function. So one of the big problems is that when the heart is not working as well, it affects other organ systems which produce hormones. And those hormones also have an effect on the heart. So a lot of times people end up in a negative cycle where your organ systems, for example, if you have a deficiency in a hormone, that would affect the heart. And because the heart is then affected, less blood goes to the place where that hormone is being produced and leads to a negative vicious cycle. So that's the first thing. The second thing to say is, in general, I would say when we're looking at cardiac dysfunction, I've thought really hard about it. I think there are three things that happen. All cardiac disease is about three things. And the ultimate problem with all of this is that the heart is a pumps out less blood. But for your viewers, the first thing that can go wrong with the heart is the heart muscle itself. The heart itself as a pump is not able to do as much. So the heart as a pump is in some way damaged or compromised. So people with cardiomyopathy, they have a weak heart. People with valve problems, the heart is not able to pump out as much blood because the valve is narrowed or the valve is leaking. So that's one problem.
And the leaking causes it to regurgitate back.
And it goes back, so less comes out because some goes back. So so that's one problem. The heart is a pump. What is that doing? The second problem is that the heart as a pump may be good, but the blood supply to that pump is in some way compromised. Those are the people who get the atherosclerosis, coronary disease, heart attacks, etc. And that's why we should always think of the heart as a cardiovascular system, not just the heart, but actually the blood supply as well. And then the third thing to say is the third thing that can go wrong are the electricity. So the heart is an electrical structure, and cardiac dysfunction will increase the likelihood of electrical problems, and electrical problems are more likely to cause cardiac dysfunction. And when we look at hormones, many of those hormones actually have receptors within the heart, and therefore optimal functioning of the heart is dependent on the right balance of those hormones. And if there's a disruption in those hormones, it may affect the heart negatively. Another bit of insight that I wanted to share with you is that for a long time we've said, okay, cardiovascular disease increases with age. We see that all the time. As you get older, you're more likely to have cardiovascular disease. But it's also very interesting to note that a lot of our hormones change with age, and some of the hormones that we have in our youth start declining as we get older. And increasingly, we're beginning to start saying, well, is it just about aging, or is it about these hormones getting less that could be affecting our heart in a negative way?
Is that the camp that you sit on? Because there are others who say, well, that's just the way it is. And the hormones decline as you age, and that's supposed to be healthy because that's your body's pre-programmed to have these lower hormones when you get older. But I don't. I think, if you had healthy hormone levels when you're younger, you didn't have the diseases that come with aging when you're younger. So therefore, if you can maintain those healthy levels throughout, you shouldn't get these other issues.
And you're right. The first thing is all viewpoints should be acceptable. The second thing is that the correct way to do this is to say, let's design good experiments to answer that question. What we shouldn't be doing, and what a lot of people do, particularly in the medical profession, is that we've got a medical degree. You're talking nonsense. You're not allowed. Shut up. That's what they do. That's completely the wrong thing to do, because how are we going to improve the care that we deliver unless we listen, unless we consider alternative viewpoints and then say, okay, that's interesting. That's what some people think. Let's design an experiment. Let's answer the question. The problem in the scientific world is that those experiments are not necessarily designed to answer the question. Those experiments are designed to give you an answer that people want to necessarily hear. Or, there's a vested interest in the result. And I think it should be that the vested interest should be in the question. Whatever the result is, it's a valid result. But unfortunately, if a result doesn't show something dramatic, then journals will not be interested in publishing it. And this is fundamentally the problem that we face.
Well, sometimes the bias in the researchers, they draw the wrong conclusion from the data, or they pick apart one piece of it. I think I pointed out in that Traverse study, like Dr. Stephen Nissen from the Cleveland Clinic, he's in every publication, or commenting on everything that has to do with heart, cardiovascular, testosterone, and he's always had, at least from what I can tell, a bit of a negativity towards testosterone, though, albeit in the latest Traverse study, he seems somewhat cautiously optimistic about testosterone's benefit, but I think almost being dragged along reluctantly. But I don't know the guy. I've just been following his work throughout the years. He was the one that back in 2003, there was a big publication on liquid Drano for the heart, which is kind of an American thing to unclog your drains. And basically, they created this HDML mimetic. I don't know if you remember this back in 2003, 2004, and it made all the headlines. And then apparently, this was quickly purchased by Pfizer, and then just kind of stored away for ages. So the initial clinical trials looked very good. If you give an IV treatment of this mimetic of HDL that was modeled after these people who lived in this small village of Sicily, then they would clear out like liquid Drano the blood vessels of the patients as a potential therapeutic. But because Pfizer couldn't sell their Torcetrib, which was their HDL raising medication, they found that people were dying from that drug rather than helping them. So raising HDL no longer became the priority, and it was shelved. So again, it's like the direction of the pharmaceutical company and they kind of all the big boys play together.
Yeah, I agree with that.
Their own kind of agenda that they follow.
And that's why you need more state-sponsored research, don't you? Rather than, we are very much, whatever is out there is very much, it's not based on trying to get to a higher form of truth. It's to try and get to a result which in some way helps the scientist progress in their career.
It's a shame because from a patient point of view, and that's why we do a lot of patient advocacy, lots of us are kind of enthralled or hopeful that these studies will give us answers to some of our own medical conditions and problems, or give us some reassurance that we're not, messing about or hurting things. Because there's a whole other way to say just sod it all and just let nature take its course and no medications. You can go the complete opposite way. And then there's another theory that, I've always espoused as, better living through chemistry, in the sense that, there are certain hormones or interventions that you can do to live a healthy life. And there's a whole movement now. I don't know if you've seen the biohacking movement. Are you familiar?
Yeah.
So there are people who are completely healthy. They're trying to stave off and ward off the signs and symptoms of aging, and they're taking metformin, rapamycin, acarbose, a host of other molecules, vitamins, supplements. There's this guy named Brian Johnson who claims he's reversing backwards. There's a whole industry of testing that goes on. The normal medical community or the sick care community is only dealing with the sickest patients and not really paying much attention to optimizing health.
Yeah. I mean, one of the things I've become very conscious of, having spent more time, is that as you gain more and more experience, you'd think that you start getting to know everything. And as I've gained more experience, I've started realizing how little I know, because no matter all this focus, all this research, everything that we're doing, it's not like we have suddenly made a dramatic difference to the incidence of heart disease. In fact, heart disease is becoming even more prevalent than it has. We're a bit better at sort of patching things up after something breaks, but we're not very good at preventing the thing from breaking in the first place. And that, I think, is really interesting, because a lot of people don't want to get to the stage where you break first and then you go and have your stent, and then you go and this, and everyone says, okay, look, this is, you want to stop breaking in the first instance. And that, I think, is the real unmet need. How do we keep people healthy for longer before they break? And there's very little that anyone is doing, because a lot of research is pharmaceutical-sponsored research. The pharmaceutical industry is interested in people who've broken, not people who are yet to break, so to speak.
Well, that's a frustration, because, let's say you are on all these supplements and medications, and then you do have an incident and you do end up in hospital. Lots of those so-called preventative measures are taken away. Those tools could be taken away from that patient, or at least whilst in hospital, and even discouraged after.
Yeah.
So what does a patient do then? I mean, how do they fight this misinformation potentially, even though it might be good intention by the people caring for them, with what they know intrinsically from years of being on hormone treatment, and now all of a sudden it comes into question because an uninformed medic at the location of that let's say cardiovascular event or heart event tells them no, you shouldn't do this. So how does a patient combat that sort of mentality? They have to hold steady, but you can erode their own confidence potentially.
It's an interesting thing. I'll tell you about my insight into this. I mean, I get lots of people who say, look, my doctor says I need to be on a statin. I feel fine. I feel very uncomfortable about taking a statin. And I say, well, the reality is, if you take a statin, you'll never know. You'll never know whether it's done anything. The doctor's saying it, that, oh, it's good for you. But you as the individual, how do you know that by taking this, I've warded off a heart attack or I've lived more than I was intended to? You'll never know. So no one knows. Your doctor doesn't know. You don't know. So the only thing you can be certain of is that if you don't take the statin and if you have a heart attack, then they'll blame you. That's the thing, right? If you take a statin and you still have a heart attack, they'll say, well, that just happens, that's all right. No one goes back and reflects and says, okay, well, they've still had a heart attack despite a statin, so doesn't that in some way reflect the fact that we need to do something better? That is just, well, what do you think? That's why we've been saying take a statin. Well, now you've had another heart attack on the statin, that's by the by. But if you didn't take the statin and you had a heart attack, well, that's definitely your fault, because had you listened to me and taken the statin, you wouldn't have had this.
And it seems to be a new push for statins on lots of people. They're seeing lots of people aren't getting. I mean, what's your take? I guess it's not that favorable for a statin, or in some cases it could be beneficial. Or
I think it's a case of, I very much, again, don't know, because no one knows, right? I'm traditionally trained. You get told these are your guidelines. You spend all your time a little bit like a circus monkey trying to follow those guidelines and making sure no one else is thinking that you are practicing outside of those guidelines. And again, I don't know. I'm relying on the data that I'm provided with. But the difference, the thing that has helped me is that I believe that patients should be stakeholders in that decision-making process. It is not a case of me just saying, take a statin. It is a case of me sitting down and educating the patient, working out what works right for them, what is aligned best with their values, and etc., and giving them the data. Just give them the data and say, these are the data. The data is the data, right? It's not like I know different data to someone else. The data is the data. You present the data in a language that patients can understand, and you say, these are the numbers. Do they work for you?
Because there are that's a good point, but sometimes the patient doesn't always know what was.
No, but the thing is that the patient deals with risk all the time in their day-to-day lives. We deal with risk when we cross the road. Why are we pretending, or why are we making the patient feel like he cannot participate in this, So you show some people are very risk averse. They'll say, okay, I want it. Perfect, go for it. Some people may say, well, those numbers don't work for me. In which case, I don't think that means then, oh, the patient's difficult, or the patient needs to be thrown out, or whatever. You say, okay, well, that's you. My job is here to support you. And my accountability is towards you, not the protocol.
So just quick on the statins, because, again, it's kind of individual, but yet it's, almost like gospel that you must have a statin if you have high cholesterol, though that's changing with the rise of the PCSK9 inhibitors, where I can explain for everyone who doesn't follow this, is PCSK9, where this is a gene, right? It's a protein that if it's elevated, you have a lot of it. People who genetically have a lot of it were more prone to having atherosclerosis and cardiac events. And there were also a subset, or I think a woman that had a gene that made very little PCSK9, if at all. And they found that she had no cardiovascular events and very low LDL. And so then they had proof in the real world from this genetic abnormality that if we can lower this PCSK9, then we would lower the cholesterol, and it should now lower cardio events. I think they have shown it the secondary events, because that's how they tested on patients. Did it decrease the secondary event? That was for PCSK9 inhibitor, but it's not lowering it as much as they thought due to the lowering of the LDL. So that begs a question. And we've always said, like on the channel when we talked about pentoxifylline, the disease is atherosclerosis. It's not high cholesterol, yet it's all made up to be that. So we might end up finding out that the cholesterol number isn't the only factor, but just part of the picture. And where now they think the PCSK9 inhibitor also reduces inflammation, but that's what they've been saying about the statins as well. But the statins, right, they work at a higher level with the HMGA co-reductase enzyme, and that's a whole chain of other events that it affects negatively, and people complain about muscle pain. It might increase diabetes. So I didn't mean to take away. What are your thoughts on the dangers and the pros of the statin versus maybe trying a different method?
So the first thing is that the only two things that matter, okay, the only two things that matter for anyone is length of life and quality of life. That's all that matters, right? And a lot of this is about trying to reduce future risk. That's why people take statins, okay? Now, the data suggests that if you have had heart disease or heart attacks, etc., then taking a statin may reduce your future risk. It's not that it's a small amount. It's a small amount from the data. So the problem is the message has come across, take a statin. What you want to know, what you want to tell patients is what is the benefit of the statin, meaning how many people do you have to treat on the statin to make one person live longer? And that number is pretty big, it's not a small number. It's not like, oh, you treat 2 people and you'll make one live longer. It's in double figures, and certainly sort of anywhere between 50 and 100, something like that. And then the second thing is, what does that benefit look like? When you say live longer, what? Live longer by a day? Live longer by a year? Live longer? And that data should be given to patients. So when I get a person who's had a heart attack, I would say, look, these are the data. You have had something, so we want to do something to try and help you. And if you are agreeable to this, great. What I would say, however, is you shouldn't take anything that makes your quality of life worse, because this is a benefit you will never realize. Someone else, we don't know. You will take the statin and no one will know whether you've lived longer as a result. So if there is a benefit that you will never know about, then the one thing you shouldn't do is do it at the cost of the thing you do know about, which is your quality of life. So if I'm giving you something that, or take this, you'll live longer, but it's making you miserable all the time, then I don't see, it doesn't make sense for that patient to be taking that. So that's how I get around it. I talk to the patient, I tell them that, look, you've had a heart attack, there's a higher chance you'll have another one. We feel that we need to do something. So what are the things that work in this setting? 1, lifestyle, 2, statin. Lifestyle and statins a little bit. What do you want to do? And if the patient says, look, I'm in agreement with you that I would like to take the statin, I'll say, well, take it. And if you develop side effects or if you develop problems with it, let's talk. I don't see any reason why I'm not here to make your quality of life worse just to make myself feel better.
And what about PCSK9 inhibitors? What are your thoughts on that?
I mean, PCSK9 inhibitors, again, they're very good at lowering cholesterol. There was one study called the Glagoff study where they found that actually they reduced atheroma as well. So the atheroma burden actually got less, but only by 1% or something. Oh.
The study, interesting, where they always would have it as an adjunct, a sidekick with a bloody statin, which is annoying because they can't let that one go. Like you can't use, I mean, there were studies, a group that had it on its own, but it's always, it seems that is so rife with politics of medicine, the way those two go together.
And this is one of the biggest problems, because what they say is that what they do is no one has the courage now to say, okay, well, for example, if you're giving something like, let's say, you've never had a heart attack, but you are someone they think, oh, you're at risk. They'll say, oh, take some aspirin, But there's really no good evidence that in the absence of actually documented heart disease, an aspirin benefits. But then the problem is that once that gets sort of embedded into medical practice, then any research study comes along, they say, oh, well, we can't stop the aspirin, so let's just add something else on and compare it with the aspirin. The problem here is that you see this is the big problem with polypharmacy. Let's say something lowers your risk of dying by 50%. Okay, so you give this person this medication. You then add in another medication that also lowers your risk by 50%. The problem then is, what has happened is, you've actually only helped another 25% of the population. You've not helped all of them. You've only helped another 25%. But you have doubled the number of medications. Now, 50% is an amazing benefit. Most of these medications are like a 1 in 100 benefit. So, you're piling on more and more tablets, getting less and less benefit, but increasing the burden of polypharmacy, the risks, the costs, and everything else. And so now people are going home on 7, 8 different tablets, having never had a tablet before. And I'm not sure whether, the data support the fact that these make so much of a difference. Maybe they make a tiny bit of a difference, but we concern ourselves with treating populations. Get everyone to wear a helmet all the time, and you'll save someone if the roof falls, right? That's what it is, isn't it? But actually, that isn't the unmet need. People want to be treated like individuals. They don't want to be treated like a population. They don't want to be treated like a data set. And therefore, we need to be spending more time with people, not only talking about what we know, but also telling them about what we don't know. And that, I think, is the purpose of medicine. The purpose of medicine is not to dish out tablets. The purpose of medicine is to support patients, to engage with them, to empathize with them, to educate them, and to empower them, to make decisions that are right for them.
We've barely scratched the surface for your hormonal health. If you like content like this, check out our other videos that discuss hormone health and optimization. And for future content, please hit the subscribe button and the notification bell so you don't miss anything. To your health and optimal hormones. See you next time. This is Mike.